This lecture has been prepared as an integral part of the project developing a higher education curriculum in SET teaching for the health, protection and promotion of intellectually disabled individuals. Hi, my name is Sabina and I will talk about the COVID-19 pandemic outbreak. Learning outcomes are: develop the ability to understand the fundamentals of infectious diseases, specifically COVID-19, including its transmissions, symptoms, and potential complications. Develop the ability to understand the key concepts such as vaccine types, vaccine schedules, herd immunity, and the benefits of immunization. Learn how to effectively communicate accurate and reliable information about COVID-19 to others, promoting awareness and dispelling misinformation. Learn advantages of public health interventions and their role in controlling the spread of infectious diseases, with a focus on COVID-19. COVID-19 pandemic outbreak. Coronaviruses are a type of virus. There are many different types and some cause disease. A coronavirus identified in 2019, SARS-CoV-2, has caused a pandemic of respiratory illness called COVID-19. The first case of COVID-19 was reported on December 1st, 2019, and the cause was then new coronavirus, later named SARS-CoV-2. SARS-CoV-2 may have originated in an animal and mutated to cause diseases in humans. In the past, several infectious disease outbreaks have been traced to viruses that came from birds, pigs, bats, and other animals and mutated to become dangerous to humans. Research continues, and further studies may shed light on how and why the coronavirus evolved to cause a pandemic. Symptoms appear in humans within 2 to 14 days of contact with the virus. A person infected with coronavirus is contagious to others up to 2 days before symptoms appear and remain contagious to others for 10 to 20 days, depending on the immune system and severity of the illness. COVID-19 symptoms include cough, fever or chills, shortness of breath or difficulty breathing, muscles of body aches, sore throat, diarrhea, headache, new tiredness, nausea or vomiting, congestion or runny nose, new losses of taste or smell. Scientific literature has extensively documented the varying manifestation of COVID-19, ranging from mild or asymptomatic cases to severe illness with multiple organ involvement. While some individuals infected with the coronavirus experience only mild symptoms or remain entirely asymptomatic, others can develop more severe complications. In certain cases, COVID-19 can lead to respiratory failure, resulting in long-term lung damage or heart muscle impairment. Additionally, the virus has been associated with nervous system disorders, renal failure, and even mortality. Who is at risk? This video teaches students what health equity means and how different types of risk factors increase or decrease a person's risk for disease. After this video, students will be ready to participate in an activity and group discussion about disease risk. Education video is part of CDC academic curriculum. Video is produced by CDC NERD Academy.
You hear on the news that a disease is spreading rapidly in your city. The hospitalization rate is steadily increasing. Several people have died, and public health experts are trying to identify the cause. The disease appears to be affecting some groups of people more than others. Data about the disease also suggests that some groups are more likely to experience severe symptoms and be hospitalized than others. A team of public health experts is investigating the disease outbreak. The team is collecting data and information to identify communities most affected. They are also working with local organizations and making recommendations for how to distribute community resources, reduce disease spread, and support health equity. Health equity means ensuring that everyone has the chance to be as healthy as possible and no one is disadvantaged because of where they work, learn, live, and play. The team may begin by considering possible exposures. In this disease outbreak, an exposure is contact with a disease-causing agent. The consequences of an exposure often depend on factors such as age, immunity, and a person's other health conditions. A risk factor is a characteristic or behavior that increases a person's risk for being exposed to an infectious agent or experiencing severe disease. For instance, the bacteria that causes cholera is often found in contaminated water. People become infected by drinking this water. So, drinking untreated water is a risk factor for cholera. Similarly, having the BRCA1 gene mutation is a risk factor that increases a person's risk for developing breast cancer. Infectious diseases only occur if a person is exposed to a specific infectious agent, such as a virus. So, to get the flu, you must be exposed to the influenza virus. Because the flu is a respiratory disease, risk factors, such as being in poorly ventilated, crowded indoor areas with people during flu season, increase the risk for exposure and developing the flu. Risk factors for non-infectious diseases like heart disease, cancer, autism, and Alzheimer's disease aren't as easy to determine. Often, a disease may have multiple risk factors. For example, cigarette smoking, high cholesterol, and high blood pressure are all risk factors for heart disease. Some risk factors, such as cigarette smoking, may be linked to multiple diseases. How do public health experts determine something is a risk factor for a disease? They use math, of course. Specifically, they count, divide, and compare. An easy way to remember this is to think CDC, count, divide, compare. First, they count the number of cases of disease and divide it by the total number of exposed people. This is the risk for disease in people who are exposed. For example, the risk for lung cancer among smokers. Then, they do the same calculation for the non-exposed people. This is the risk for disease in people who are not exposed. For example, the risk for lung cancer among non-smokers. Finally, they compare these risks by dividing the risk among the exposed group by the risk among the unexposed group. This comparison is called the risk ratio. The risk ratio provides a measure so experts can see if the amount of disease among the exposed group is similar to, greater than, or less than the amount of disease in the non-exposed group. The risk ratio also quantifies how strongly associated an exposure or having a particular factor is to a disease. If the ratio is 1, then the exposed population has the same risk for disease as those who are not exposed. So the exposure does not increase or decrease the risk for disease. A risk ratio above 1 indicates that the exposed group has a greater risk for getting the disease than the unexposed group. For example, the risk ratio for breast cancer among women with the BRCA1 gene mutation is about 6, meaning that women with the BRCA1 gene mutation are about 6 times more likely to develop breast cancer than women without that mutation. The larger the risk ratio, the stronger the association between an exposure and a disease. It is important to remember, though, that a risk ratio doesn't actually tell you how common a disease is. It just tells you the risk for the disease in the exposed groups as compared with the unexposed groups. Some risk ratios are less than 1, indicating that the amount of disease among the exposed group was less than among the unexposed group. You find risk ratios less than 1 for factors that may be protective, like getting the flu vaccine to produce immunity to the flu, or wearing sunscreen to avoid getting skin cancer from the sun's ultraviolet rays. Factors that affect health in a positive way are called protective factors. Protective factors decrease a person's risk for developing an undesirable health outcome. A person's health is affected by many factors, including their biology, their choices and behaviors, and their environment. Risk factors can be roughly categorized into these three groups: biological risk factors, behavioral risk factors, and environmental risk factor. Some of these factors that influence health, such as a person's age or their genes, are impossible to change. However, some of these factors can be changed by the personal behaviors made by individuals, such as whether they smoke or exercise. But many factors are complex and not as simple as an individual making a choice. These factors that influence health may be related to the environment around a person. Examples include stress at a job, having safe areas outside to play, or access to resources like healthy food, healthcare, and quality education. Biological risk factors such as age and genetics are part of who someone is and can't be changed. However, sometimes when these risk factors are known and increase a person's risk for disease, actions can be taken to lower the risk. For example, people who have a family history of high blood pressure, a known risk factor for heart disease, can try to lower their risk by eating less sodium in their diet. Their genetics may make them more susceptible to high blood pressure, but their behavior can help lower their risk for getting it, or help decrease the severity of high blood pressure if they do get it. For another example, flu can be especially severe in very young and in older age groups. A person's age can't change, but all people 6 months of age and older can get a seasonal flu vaccine every year to help lower their risk for getting flu or help decrease the severity of flu if they do get it. Behavioral risk factors, such as lifestyle choices and following prevention measures, can increase or decrease risk. Because they can be changed or modified, some people may have the ability to change these behaviors and reduce their risk for disease. For example, smoking may increase the risk for diseases like lung cancer, while drinking more water and fewer sugary drinks may help protect against obesity. Prevention strategies like washing your hands regularly can help decrease your risk for disease. Behavioral scientists like Brandon study the behaviors of people and how they may contribute to disease or protect against disease and other poor health outcomes. Brandon also works with statisticians to understand the factors that put members of his community at risk. Brandon collaborates with other public health experts to design tailored strategies to help improve health outcomes for different groups of people. Brandon works to encourage healthy lifestyles through behavior change and educational outreach. For example, because smokers are more likely to develop lung cancer than those that do not smoke, and 9 out of 10 adults who smoke cigarettes daily first try smoking by age 18, Brandon might work with local schools to develop appropriate campaigns to discourage kids from ever starting to smoke. Brandon might also help answer questions about how a sex education program can provide students with the knowledge and skills to help them make healthy choices and avoid human immunodeficiency virus, HIV, sexually transmitted disease, STD, and unintended pregnancy. He might also work with a local clinic to help answer questions for people hesitant to get the flu vaccine. A person's health can also be influenced by environmental risk factors in environments where people work, learn, live, and play. These social determinants of health can affect a wide range of health risks and outcomes and aren't always entirely within an individual's control. But education and public health initiatives can help address these social determinants. There are 5 main categories of social determinants of health: education access and quality, healthcare access and quality, neighborhood and the built environment, social and community context, and economic stability. Education access and quality includes the effect that educational opportunities have on people's health and well-being. People with higher levels of education are more likely to be healthier and live longer. Providing high-quality educational opportunities for children and adolescents and helping them do well in school can lead to safer, higher-paying jobs, better insurance, and access to healthier environments. Healthcare access and quality is the connection between the availability of healthcare services and health. Increasing insurance coverage and access to healthcare professionals can make sure more people get important healthcare services, like preventative care and treatment for chronic illnesses. This also includes access to health information so people can make informed health decisions. Neighborhood and the built environment is the connection between where people live and their health. Improving access to and the quality of housing, transportation, and recreation areas can all improve physical and mental health. Increasing the availability of healthy foods, air, and water quality, and the safety of neighborhoods by reducing crime and violence also positively affects health. Social and community context includes relationships and interactions with family, friends, coworkers, and community members that can have a major effect on people's health. A sense of community or civic participation might positively affect health, but discrimination or hostile workplace conditions might negatively affect health. Racism is a system that assigns value and determines opportunity based on the way people look or the color of their skin. This gives some people unfair advantages and causes other people to be treated unfairly. Addressing factors contributing to these differences is important for improving overall health and well-being of communities. Economic stability is the connection between financial resources and health. Income and other financial resources greatly affect a person's ability to access healthy food, stable housing, and other needs that influence both physical and mental health. Providing programs such as career counseling and maintaining policies that help people pay for food, housing, and healthcare can help people achieve economic stability. An individual's well-being and health outcomes are affected by a complex combination of biological, behavioral, and environmental risk factors. Part of Brandon's job as a behavioral scientist is to educate people about factors that influence health and how they can make better choices to limit risk factors they can control to improve personal health outcomes. Brandon and other public health experts work to understand how systems and policies influence health, so that they can promote those that help support health equity. Remember that health equity is only reached when every person has the opportunity to reach their full health potential and no one is disadvantaged because of their social determinants of health. As a recap, let's answer the question, who is at risk? Some people have risk factors that increase their risk for getting a disease or experiencing more severe illness. In a disease outbreak, an exposure is contact with a disease-causing agent. There are many factors that determine whether an exposure will lead to an infection or to experiencing severe disease. A risk factor is a characteristic or behavior that increases a person's risk for being exposed to an infectious agent or experiencing severe disease. There are also protective factors, which protect a person and reduce their risk for disease. Risk factors can be identified using a ratio. When the risk ratio is greater than 1, the factor is associated with a higher risk for the disease. If less than 1, the factor may be protective against the disease. Risk factors can be roughly categorized into 3 groups: biological risk factors, behavioral risk factors, and environmental risk factors. You have control over some risk factors, like behaviors, but not others, like biological factors such as age and genetics. External or environmental factors also influence health, and you may not have full control over some of these. These social determinants of health are the conditions in the places where people live, learn, work, and play that affect a wide range of health risks and outcomes. By applying what we know about social determinants of health, we not only improve individual and population health, but also move us toward achieving health equity.
The basics of immunization. Immunity is the biological state of being resistant to a disease or toxin. The main goal of vaccination is to create immunological memory against certain diseases so that the immune response neutralizes the infection or toxins it releases before the disease occurs when exposed to a pathogen. Immunization is a fundamental public health intervention that aims to prevent infection diseases by stimulating the body's immune system to recognize and fight specific pathogens. It involves the administration of vaccines which contain weakened or inactivated forms of the pathogen or its components to reduce an immune response without causing the disease itself. Immunization has been a highly successful strategy in reducing the burden of infectious diseases worldwide and has saved millions of lives. The basics of immunization include several key principles and practices. Vaccine development and safety. Vaccines are developed through a rigorous process of scientific research, testing, and regulatory approval. Safety is a top priority, and vaccines undergo extensive clinical trials to assess their effectiveness and safety profile. Multiple layers of monitoring and surveillance systems are in place to identify and address any potential adverse events following immunization. Types of vaccines. There are different types of vaccines, including live attenuated vaccines, inactivated vaccines, subunit vaccines, toxoid vaccines, and conjugate vaccines. Each type elicits a specific immune response and might require different dosing schedules. For example, live attenuated vaccines contain weakened forms of the pathogen, while inactivated vaccines use killed or inactivated pathogen. Vaccine schedules. Immunization schedules outlined the recommended timing and sequence of vaccines for different age groups, considering the vulnerability of certain populations and the optimal immune response. These schedules are developed and regularly updated by national immunization programs in consultation with global health organizations such as the World Health Organization and the Centers for Disease Control and Prevention. Herd immunity. Vaccination not only protects individuals but also plays a crucial role in achieving herd immunity or community protection. When a significant proportion of the population is immunized, the transmission of the pathogen is disrupted, protecting those who are vulnerable or unable to receive vaccines, such as infants, pregnant women, or individuals with compromised immune systems. Vaccine-preventable diseases. Vaccines have been developed to prevent a wide range of infection diseases, including measles, polio, hepatitis B, influenza, pneumococcal diseases, human papillomavirus, and many others. Each vaccine targets a specific pathogen and confers immunity against the associated disease. Immunization has had a profound impact on global health, contributing to the eradication of diseases such as smallpox and the near elimination of others like polio. It has also been instrumental in reducing the burden of childhood diseases, preventing complications, hospitalizations, and deaths. For example, the introduction of the measles vaccine has led to a significant decline in measles-related morbidity and mortality worldwide. For example, smallpox was a highly contagious and deadly disease caused by the variola virus. Through a global immunization campaign led by the World Health Organization, smallpox was successfully eradicated in 1918. This achievement stands as a testament to the power of immunization and collaborative efforts in eliminating a disease that had plagued humanity for centuries. It is essential to maintain high vaccination coverage rates to sustain the benefits of immunization. Vaccination campaigns and routine immunization programs ensure access to vaccines for individuals of backgrounds regardless of socioeconomic status or geographic location. Efforts are also made to address barriers to immunization, such as vaccine hesitancy, lack of awareness, and logistical challenges. Where do public health data come from? This video introduces students to the concepts of where do public health data come from. This video teaches students that disease surveillance mean and how surveillance systems help public health experts determine if there is a problem. After this video, students will be able to answer the question, where do public health data come from? And they will be ready to participate in an activity and group discussion about public health surveillance. Educational video is a part of CDC Academy curriculum. Video is produced by CDC NERD Academy.
When you hear the word surveillance, what does it make you think of? Spies? Video surveillance cameras in stores and on buildings? Spies and surveillance cameras are constantly monitoring to collect information that might be useful in some way. The information collected is used to detect problems and help inform actions. Public health surveillance is similar, but uses different tools and strategies to collect information. It starts with experts, like epidemiologists, who constantly monitor what diseases are occurring in the community. They collect and analyze data to identify problems and take action. They review disease data from sources such as laboratories, doctors' offices, and hospitals. When you hear about the number of COVID-19 cases in a state or an outbreak of Ebola in a country, those reports come from public health surveillance. Like a dog that barks in the night, surveillance systems alert public health experts when something unusual might be going on in a community. Sometimes a dog barks because someone is outside the door. Sometimes a dog barks at the wind, or nothing at all. The only way to find out is to investigate. Similarly, when a surveillance system detects an increase in cases, public health experts must check the data to take a closer look. It might indicate a real outbreak is occurring, or it could be a false alarm. In setting up a surveillance system, it is important to first determine its purpose and goals. One main reason to do surveillance is to let health experts know when they need to take action. Surveillance data provides answers to questions like, do we have a problem? And if so, how big is the problem? After taking public health actions to address the problem, surveillance data can also answer, are the steps we're taking working? So the data must be accurate and timely. When public health experts have identified the purpose and goals of their surveillance system, they then must decide which diseases to include, what data to collect, and how to collect it. In deciding which diseases to include in their surveillance systems, public health experts in each state develop a list of diseases that health facilities, such as hospitals, should report to the health department if cases are detected. These are called reportable diseases, and the cases can usually be confirmed by laboratory testing. Health departments collect data to monitor these diseases because they can cause serious illness or can spread easily from person to person or can cause deadly pandemics. Examples of reportable diseases are rabies, measles, and COVID-19. Determining which data to collect starts with addressing case definitions. Case definitions are used in both surveillance and in outbreak investigations. A case definition is developed for each disease that health experts want to monitor. It provides a set of criteria to define when an instance of disease should be counted as a case. Some case definitions used in surveillance systems are very specific and require laboratory confirmation to ensure that the person has that disease and not something similar. Other case definitions may be written more generally, requiring only that the illness matches a description of common signs or symptoms. The case definitions for many reportable diseases are standardized so that the data collected in different places can be compared. Public health experts collect information about people and their disease, including the patient's name, address, phone number, age, sex, gender, race and ethnicity, and occupation. These personal characteristics collected about a person with a case of disease are called demographic information, sometimes demographics for short. Demographic information is generally followed by clinical information, such as signs and symptoms, the date the illness began, and the name of the disease, if known. Signs of a disease are the objective observations noted by a healthcare provider, such as jaundice, rash, or diarrhea, and symptoms are subjective reports by the patient, such as pain, nausea, or fatigue. Information on laboratory testing generally follows clinical findings. This includes samples collected, collection dates, and test results. Other information may be collected, including possible places the person could have been exposed, such as a child care center, or noting behaviors that could have contributed to a person becoming infected, such as injecting drugs or not washing their hands after being around animals. Finally, public health experts must consider how best to collect the data. To make this decision, they consider the amount of resources available, like time, funding, staffing, and equipment, the type and possible sources of data, and how and when the data will be used. The different ways of collecting surveillance data can be generally categorized as passive, syndromic, or active. Let's begin with an example of a passive surveillance system. Typically, if a doctor diagnoses measles in a child, the doctor will enter her report into an electronic health record system. A series of automatic events will identify this case of measles as a reportable disease and automatically send the report to the public health department. The health department may follow up by calling the patient or their parent, if a minor, to ask additional questions concerning possible exposure and follow-up. This is a passive surveillance system because the health department waits passively for the reports to come in. Depending on the disease and situation, health departments may also notify other public health agencies like the U.S. Centers for Disease Control and Prevention, or CDC. This information is added to CDC's National Notifiable Diseases Surveillance System, which tracks about 120 diseases across the nation. These include infectious diseases such as Zika, foodborne disease caused by E. coli, and non-infectious conditions such as high levels of lead in a young person's blood. The National Notifiable Diseases Surveillance System helps all levels of public health, local, state, federal, to share health information to monitor, control, and prevent spread of disease. It can take days or even weeks after a person first feels ill for a doctor to determine what disease that patient has, for lab tests to confirm the diagnosis, and for the report to be sent to the local health department using a passive surveillance system. During this time, outbreaks may go undetected, and timely intervention may be delayed. A newer type of surveillance, syndromic surveillance, was developed to address these challenges. Syndromic surveillance relies on computer algorithms to review information automatically reported from every healthcare visit to find patterns of concern. For example, a syndromic surveillance system may identify an increase in sets of signs and symptoms that are linked and consistently associated with a disease, such as fever plus widespread rash. A group of symptoms which consistently occur together are referred to as a syndrome, which is where the system got its name. An unexpected increase in the number of people experiencing illness could suggest an outbreak that should be investigated. Although further investigation and time may be needed to determine the exact cause of the illness, the power of syndromic surveillance is that it can alert public health experts several days before a problem is detected through passive surveillance. Syndromic surveillance is also useful to help monitor and describe how an event of public health concern is changing over time. While passive and syndromic surveillance systems can sound the alarm about increases in disease, they are subject to significant underreporting and may give a false impression of where the problems really lie. For instance, syndromic surveillance can show there's an increase in the number of people being treated in an emergency room with nausea and vomiting, but it only picks up those people who went to emergency rooms. To get a more accurate picture of what is going on, public health experts might use an active surveillance system. With this system, public health experts actively seek out more information by contacting laboratories, hospitals, healthcare providers, and other patient care settings to review medical records and identify cases that may have gone unrecognized and unreported. Public health experts may even set up community testing sites to identify additional cases. These active surveillance systems are typically short-term and are used in outbreak responses. Active surveillance systems give a more accurate picture of the size of the problem and help identify individuals who may need to be treated, isolated, or quarantined in order to prevent additional infections. After public health experts have collected passive, syndromic, or active surveillance data, they must analyze and interpret the data and decide what actions, if any, are needed. The standard approach for analyzing surveillance data is to summarize the data by who, where, and when, also referred to as person, place, and time. Analyzing data on person requires looking at demographic information, such as age, sex, gender, race, ethnicity, and sometimes other characteristics like socioeconomic status, access to medical care, and activities, such as occupation and hobbies. Analyzing data on place involves looking at where the patients live, work, or go to school. Are there clusters in specific areas? Analyzing data related to time involves looking at the number of new cases by day, week, or month of onset and determining whether the number of cases is going up, staying steady, or going down, and how it compares with other years. Together, these analyses describe the pattern of disease in a community, help experts decide whether action is needed, and if so, on whom, where, and when to focus. Fortunately, Bella, a biostatistician, works at a health department and has all the specialized skills to handle the task. In her work, she uses math to analyze and summarize the collected data. To visualize the data, she creates reports with graphs that show disease patterns or trends, area maps that show cases geographically, and bar graphs that show cases by age and sex. Her reports help other public health experts assess disease trends, draw conclusions about specific health problems and actions needed, and develop strategies to control and prevent public health problems. As a quick recap, we can now answer the question, where do public health data come from? Public health data come from surveillance. Surveillance is the ongoing systemic collection, analysis, and interpretation of data about health conditions in a specific population. Case definitions are used to identify individuals who should be counted as having a case of a certain disease or health condition. The three main types of public health surveillance include passive, syndromic, and active. In passive surveillance, the health department relies on healthcare providers or laboratories to report cases. Syndromic surveillance looks at syndromes or groups of signs and symptoms, and the data are automatically collected. Active surveillance is usually short-term and requires public health experts to actively search for cases. Information from surveillance helps public health experts describe disease patterns with respect to person, place, and time. That can be used to create strategies to control the disease and prevent future health problems.